I'm Dr. David Morwood, and welcome back to Your Health radio and television program. I am a board-certified plastic surgeon, and my next guest, the esteemed Dr. Dan Luba, gastroenterologist. Dr. Luba, thanks very much for being here.
Thank you for having me.
Dr. Luba, I think there's a lot of misunderstanding about what a gastroenterologist does, and in fact, what a gastroenterologist is. Let's talk about your training. How does one get to be a gastroenterologist?
Well, you go through undergraduate school, then go to medical school. After you do medical school, you usually complete a residency in internal medicine and then do a fellowship in gastroenterology.
So again, now you're a trained internist. Now you could have elected to go out and practice internal medicine, but you chose to do a fellowship in gastroenterology.
Correct.
And how long is the fellowship?
Now it's 3 years.
Another 3 years of training. Okay, so what's the training like? What do you do for 3 years?
Usually the first 1 to 2 years you're doing clinical work, so you're taking care of patients, learning how to do endoscopies, and then usually there is at least 1 to 2 years of research.
Okay, and let's teach our audience, our listeners and viewers, what your day is like, actually what your week is like, and what a gastroenterologist does, and in fact what a gastroenterologist is.
Well, I guess we can start with what a gastroenterologist is. What a gastroenterologist is basically someone who takes care of the GI tract. So basically we take care of problems with the esophagus, stomach, intestines, colon, liver, and pancreas. And so it actually encompasses quite a lot of different things. And I spend my time taking care of patients in the hospital when they're acutely ill. I see patients as an outpatient, and we also do procedures like colonoscopies, upper endoscopies, and ERCPs.
Okay, so the entire GI tract or gastrointestinal tract is really your turf. That's your field.
Yes.
Now, isn't it true that within gastroenterology there's some super specialists, like some people only take care of the stomach, or they only take care of the liver, or they only do the colon? Is that true?
Well, to some extent. I think that liver disease is certainly a specialty in and of itself. And we have patients who undergo liver transplants, and obviously transplant hepatologists, as they're called, are a very are a definite subspecialty within GI. And then there are people who really specialize in therapeutic procedures. Some people who have extra training in, let's say, doing ERCPs, where you're actually looking at the bile ducts, and that takes more training. And so some people do subspecialize further.
Okay, so that ERCP, let's define for our listening and viewing audience what ERCP is. Now, you're testing me now. That's endoscopic, retrograde, cholangiopancreatography, is that right?
That's good. I always have to just go by the letters.
Okay. Well, what is ERCP? What is it? Now that we've told them what it means.
Well, what that does is if somebody, let's say, people usually know what a gallstone is. That's where you have a stone in the gallbladder and it causes problems. So you have to take out the gallbladder when it causes problems. There's a small duct which connects the gallbladder and there are ducts that drain the liver that then go into the gallbladder, and then that duct further drains the bile down into the intestine. Sometimes you can get a small stone in that duct, and what we do when we do an ERCP is we take a little tube that's about the size of your pinky. It's flexible, bends around corners, has a camera at the end of it, and projects a picture up onto a TV screen. Put it down your mouth, down the food pipe, stomach, into the intestine where that bile duct comes out. And then we take a little plastic tube and put it into the bile duct, and we can inject dye, take x-ray pictures, and see if there are stones there. And if there are, we can make a little incision through the scope and pluck out the stones.
Well, Dr. Luba, it sounds to me, and I've seen you guys do some work, and I know that you're terrific at what you do. It sounds to me like that requires a tremendous amount of finesse. Now, you sort of snake the tube down through the esophagus and through the stomach, down into the duodenum, is that right?
Right.
And then you sort of manipulate or almost operate through that. That's just an amazing amount of finesse to me. So our topic today, besides gastroenterology, we would like to talk about esophagitis. Now,
Okay.
I want to talk about really what esophagitis is, Does it relate to heartburn? What's acid reflux? And then we're going to have to take a few minutes to talk about Barrett's esophagitis, right? So can we start talking about heartburn or acid reflux? Is that the same thing?
Yeah. Basically, what happens is that you have your esophagus, that's your food pipe, that carries food down from your mouth into your stomach. At the bottom of your esophagus, there's a sphincter. And that sphincter, one opens up to allow food to go from your esophagus down into your stomach, but also contracts to prevent food and acid that's in your stomach from going back up into your food pipe.
So there's a sphincter that's a muscle,
right,
really, a circular muscle, and that's supposed to act as like a dam, right?
Correct.
And it allows food to go through the esophagus into the stomach, but ideally it doesn't allow food or acid to go back up. Is that right?
Correct. Sometimes that sphincter doesn't work as well as it should. And sometimes you get it being tight most of the time, but occasionally it would just relax when it's not supposed to and allow acid to come back up into the food pipe. Or sometimes it just doesn't really squeeze tight enough ever, and so you get relatively free reflux back up into the esophagus.
Okay, now is that the same thing or different or related to what we call a hiatal hernia?
It's a little bit different. The hiatal hernia, people use them interchangeably, but when you have a hiatal hernia, what happens is that your diaphragm is supposed to pinch off the top of the stomach and the end of the esophagus. It's supposed to come together right at that point. And actually what that does is it helps prevent acid from going back up because it gives the sphincter just a little bit more oomph. Sometimes a little bit of the stomach goes up above the diaphragm.
So the stomach itself?
The stomach itself is actually up in the chest when it should be below the diaphragm in the abdominal cavity. So if the stomach itself is up in the chest, a little bit of it, what happens is that the diaphragm is going to pinch off part of the stomach. It doesn't usually make that much difference, but you're not getting that extra bit of squeeze that the diaphragm can help you get.
Okay, so heartburn is real. The slang, the term heartburn is really acid coming back up the esophagus. Is that right?
Correct.
Now, people can sense that. The esophagus has some sensation?
Sometimes. Sometimes acid reflux can present in a whole bunch of different ways. Sometimes people will just complain of a burning sensation in the pit of their stomach. Other times people will get more typical heartburn, which will be a burning coming up and down their chest. Some people don't present with either of those and present with asthma, cough, hoarseness, and any of those can be other presentations that are a little bit more difficult to tease out.
Well, Dr. Luba, is it true, or is that just a tale that certain foods may cause heartburn? Like, does very spicy food really have anything to do with acid reflux, or is it not really true?
It sure does. I mean, people know it also, because if you go out, people who have heartburn, and they go out and have a pizza, they can pretty much anticipate getting more heartburn. What it does is certain foods will decrease the lower esophageal sphincter pressure and allow more acid to come back up. And that's the way they usually work.
I see. Okay, so we've talked about acid reflux and heartburn. Now, does everybody who has acid reflux have esophagitis?
No. You see, some people, acid reflux has a whole huge spectrum. I'd say probably 50% of the population, of the adult population, gets heartburn about once a month. So it's very common for people to get a little bit of acid coming back up, burning sensation. They may take an antacid and have it go away.
Okay.
Some people will get acid coming back up into their food pipe more frequently, and we like to use a cutoff of about more than twice a week is something which should be investigated. What can happen then is that you can actually get ulcerations in the esophagus. And that's when I really start to care, because if you're getting ulcerations in the esophagus, what that means is you're doing damage to your esophagus. Sometimes people can get acid coming back up into their food pipe and not cause any damage. And other times people can get the same amount of acid coming up and their esophagus can get damaged, where they get ulcers or strictures, where you get a narrowing of your esophagus, and sometimes people can even develop what we're going to talk about later, which is Barrett's.
Oh, okay. Now, I do want to get to that, But I want to summarize again. So the acid coming up from the stomach into the esophagus can sometimes cause the esophagus to be inflamed, and as you said, can sometimes actually cause an ulcer, like break down the wall. Now, is that dangerous necessarily or bad? And the other thing that I want to emphasize in terms of public service, you said that heartburn or reflux more than twice a week indicates a need to have it investigated. Is that right?
Yes.
Now, why is that? Why do you have the cutoff of twice a week heartburn means it should be investigated?
Well, when you have more than twice a week, you're getting, especially if you're over the age of 50, that's when you start to increase the risk of having ulcerations and erosions in the esophagus, which can cause scarring and a stricture, which can cause food to get stuck. And it also increases your risk of developing Barrett's, which is a precancerous lesion.
Okay, now see, Dr. Luba, we're able to do some real public service here. So Barrett's esophagitis, is that right? Those two words go together. Barrett's esophagitis. Can we define that again and tell the audience what it is?
Sure. What Barrett's is that normally the esophagus has a certain type of lining or epithelium. Sometimes the lining of the esophagus can change and look more like the lining of the small intestine. And that's called Barrett's. And that can be a precancerous change. Now, the risk of going on to developing cancer is relatively low, but it's still there. And the problem is that when we look at most cancers, the incidence of most cancers in the United States now is staying steady or actually dropping a little bit. The problem with adenocarcinoma of the esophagus, which is the type of cancer you get when you have Barrett's, that's actually increasing at a fairly alarming rate. Probably related to the general epidemic of obesity in the United States and the foods that we're eating.
I see. So not only do spicy foods increase the incidence of acid reflux, but being obese, being very heavy also does, is that right?
That will make it a little bit worse, yes.
Now, is that a mechanical issue? Is it known? Is it just more pressure pushing up on the stomach? Why does obesity lead to more esophagitis?
To some extent, and that's actually a little bit controversial because sometimes if people lose weight, their acid reflux will get better, other times it doesn't. But certainly some of the foods that we're eating will make it more, will generally tend to make people weigh more, which will also increase their acid reflux.
Okay, so I want to talk a little bit more about the relationship between Barrett's esophagitis and cancer of the esophagus. And then I want to talk about what we do about it. What does a gastroenterologist do about it? So is it clear that there's good data that chronic inflammation of the esophagus can lead to esophageal carcinoma?
Yes.
So that's clear, no question.
Well, that's the current hypothesis at this time.
Okay.
And there's fairly good data to support that.
Okay. And again, from a public service point of view, for our listeners and viewers, if there's someone who has heartburn or acid reflux more than twice a week, they should get a workup or see you, get it investigated somehow.
Correct.
Okay. So now, what do we do about this? What if someone has heartburn twice a week or acid reflux? They can tell certain foods irritate their stomach and their esophagus. As a gastroenterologist, what do you do about it?
Well, first of all, we want to find out if they're having any what we call alarm symptoms. So are they losing weight? Are they over age 50? Are they having things that are going to make them more at risk for having a cancer already present or developing into a cancer? So the first thing we can do is we can try to decide how much risk they're at. The second thing that we can do is we can treat them and make their heartburn go away. And for a lot of people, that's really a big deal because people don't really realize how uncomfortable they are. And there are medications that can be taken that can really virtually eliminate acid reflux in the vast majority of people, which has a huge benefit on their quality of life. So, for somebody who can't have a glass of wine at night because they get heartburn, or they can't go out and enjoy, a pizza or a spaghetti, or go out and get some Mexican food, it's a big deal to be able to do that, or even have a cup of coffee. Now, some people say, well, you've got to really adjust your diet. But why, if you're going to be getting symptoms we can control this stuff, for a lot of people, that's a very important thing to do. And I think to improve people's quality of life is important. The way we can investigate is by doing an endoscopy, where we take a little flexible tube, sort of similar to the one we did with the ERCP, only not as complicated. We sedate people so they usually don't remember the test, and we put a little tube down their mouth, look at their food pipe and stomach. We can see if there are any abnormalities. If there are signs of Barrett's, we can take biopsies, and then we can see if there is Barrett's, we can see whether or not it's really present and whether it's starting to progress along the lines to go towards a cancer.
Okay. Now, Dr. Luba, you know, again, for our listeners and viewers, when they hear or see scoping, a lot of questions come up. Now, are they awake? Are they asleep? Does it hurt? Does it feel like they're choking? Like what? That's what you call an upper GI, is that right?
Well, that's an upper endoscopy.
Upper endoscopy. So tell us more about what an upper endoscopy is like.
Basically, the preparation for that is just nothing to eat or drink for 6 hours before the test.
Okay.
Okay. We can do it the vast majority of the times as an outpatient. They would need to have someone who can drive them home. We would put an IV into their arm. We would give them medicine to make them sleepy. They probably would not remember the test at all. Choking or gagging is usually not a problem at all. And then after the test is done, they usually wake up and generally don't remember a thing about it. We tell them the results, and they need to have someone who can drive them home. They can't drive for the rest of the day. They can't drink for the rest of the day. The following day, they're fine.
Okay, so essentially it's a tiny little camera on sort of a flexible tube, kind of
Correct.
a snake. And do they swallow it down or you guide it down? How's that
I guide
work?
it down.
Okay. And with that, you can see and you can do a biopsy if need be. Are there therapeutic maneuvers you can do with the scope?
Sure. If somebody is having difficulty swallowing, then we can actually stretch the esophagus.
Well, that's amazing. Dr. Luba, we've only got a couple more minutes, so I want to make sure that we give out your phone number and or website. And I want to talk a little bit more about what else you can do with an upper endoscopy.
Well, the one other important thing that we can do is there is a new technique to what we call ablate, or get rid of the Barrett's, where we can actually cauterize the layer, a superficial layer of the esophagus to get rid of the Barrett's and have it turn back into normal
So
tissue.
it actually reverses the pathologic change and makes it like a normal, or allows it to recover.
Correct.
So not everyone who gets Barrett's esophagitis will need part of their esophagus removed surgically.
No, that's very, very rare for that to happen.
That's rare. But if the unfortunate event were to occur that they did get esophageal carcinoma or a cancer growing, then they get part of their esophagus removed typically, or?
There would be oftentimes radiation therapy, chemotherapy, and surgery.
Okay. So it sounds like certainly to discover it when it's early, before it's progressed, is a huge advantage to the
Correct.
patient, right?
Yes.
Okay. So so Dr. Dan Luba, L-U-B-A, and you have an office here on 68. You're in Monterey?
Yes,
Now,
in Ryan Ranch.
Do you have a website or a phone number we can give out?
Sure. Our phone number is 375-3577. And our website is currently being constructed, so
Okay.
that should be up in the near future.
So Dr. Dan Luba, 375-3577. Now, I guess we only have about 20 seconds left. My final question is, if someone feels like they're having heartburn or reflux, or they're bothered by symptoms, should they see their family doctor and then they get referred, or can they call your office directly? How's that work?
Usually they're referred, but we certainly can see people without a referral. And sometimes one thing that they do want to make sure about is that they are having heartburn and that it's not a heart problem. Because that's always something that you want to make sure about first, is that if you're having chest pain or tightness, don't just assume that it's just coming from reflux, but you do want to make sure that you don't have an underlying heart problem.
Dr. Dan Luba, that is terrific advice and a great way to end up our segment. Thanks so much for coming. I feel like we've barely scratched the surface, so please come again.
Thanks so much for having me.
Thanks for being here. I am Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to come right back after a very brief pause for a very good cause. Thanks for being here.